In my neighborhood, every Tuesday is trash day. I typically have 2 bags of trash that I sit out on the curb. The bags are filled with empty containers and objects that no longer have any use. So I'm always thankful when trash day comes around because it allows me to rid my home of solid wastes. In some ways, your body has its own form of house cleaning. It's called bowel elimination, which is the way your body rids itself of solid wastes from the digestive tract. In my neighborhood, every Tuesday is trash day. I typically have 2 bags of trash that I sit out on the curb. The bags are filled with empty containers and objects that no longer have any use. So I'm always thankful when trash day comes around because it allows me to rid my home of solid wastes. In some ways, your body has its own form of house cleaning. It's called bowel elimination, which is the way your body rids itself of solid wastes from the digestive tract. These wastes, or feces, are the remnants of undigested food that have passed through your large intestine, or bowel. Along the journey, most of the valuable nutrients and much of the water was removed from the food remnants, and the fecal matter that remains is no longer of use to your body. In this lesson, we'll learn about how feces moves through and is eliminated from the bowel. By the time the remnants of your dinner make it to your large intestine, they have been chopped and tossed and doused with powerful digestive juices. These processes broke down the food and stripped it of most of its useful products. Therefore, the functions of the large intestine are few. It absorbs some of the remaining water and nutrients from the fecal matter and moves it toward the rectum. The rectum is the last section of the large intestine that acts as a temporary storage space for feces before elimination. But before we discuss what happens in the rectum, it's important to learn how the feces moves through the main part of the large intestine, called the colon. Wastes don't just flow through your colon. They are propelled by 2 main types of movements, known as peristalsis and mass movements. While peristalsis, which is a wave-like series of muscular contractions, is not as propulsive in the large intestine as it was in earlier areas of the digestive tract, it does play a role in moving feces through the colon. More of the movement of feces through the colon is thanks to the mass movements, which are strong, slow-moving contractions that move through the large intestine 1 to 4 times a day. Even though mass movements are powerful contractions, you likely don't even notice them, as they move over your colon and force feces toward the rectum. When feces arrives in the rectal walls stretch. This stretching activates the defecation reflex, which is simply the reflex that stimulates the desire to defecate or have a bowel movement. If you don't go to the bathroom right away, this reflex passes within a few minutes, and the urge to use the restroom subsides. However, if you delay this impulse too often, additional water can be absorbed from the feces, causing it to become dry, hard, and difficult to pass. If defecation is allowed, the walls of the rectum contract, forcing the feces into the anal canal, which is the final passageway for feces before exiting the body. Muscles within the pelvic floor help to spread the walls of the canal apart, and the rectum pushes down to force the feces on its one-way path. The anus is the opening at the end of the anal canal. Here we find a pair of muscular rings that control the exit of feces through the anus, called the internal anal sphincter and external anal sphincter. Unlike the internal sphincter, the external sphincter is under your voluntary control. This gives you control over when to eliminate the waste. This is also how you house train your new puppy, Rover. With some patients, Rover learns that he needs to voluntarily constrict his external sphincter until he's let outside into your backyard. Let's review. Bowel elimination is the way your body rids itself of solid waste from the digestive tract. These wastes, or feces, are the remnants of undigested food. Feces is propelled through the large intestine by peristalsis, which is a wave-like series of muscular contractions, and mass movements, which are strong, slow-moving contractions that move through the large intestine 1 to 4 times a day. The rectum is the last section of the large intestine that acts as a temporary storage space for feces before elimination. When feces arrives in the rectal walls stretch, activating the defecation reflex, which is simply the reflex that stimulates the desire to defecate. If defecation is allowed, the walls of the rectum contract, forcing the feces into the anal canal, so it can exit the body through the anus. Here we find the internal anal sphincter and external anal sphincter, which must relax to allow the waste to be eliminated.
Poop. We don't like talking about it too much. It smells and it doesn't look all that appetizing. But the stuff we do find appetizing is what eventually becomes poop as it travels through the gastrointestinal or GI tract, which is the digestive tract of the human body. Sometimes everything goes in one end and comes out the other just fine. Other times, however, there are disturbances in intestinal elimination along the way. One of the things that can go wrong is constipation. Constipation is a symptom rather than a disease, which may be acute or chronic in nature and results in a decreased frequency in the passage of stools and/or consists of stool that is hard and difficult to pass. When I say acute, it's not a cute problem. Acute means it's of sudden onset and/or short duration. When I say chronic, I mean it is of long duration and/or recurrent in nature. There is no one established definition of constipation, so what I gave you is just an example. Constipation is sometimes seen clinically simply as less than 3 bowel movements per week. However, newer criteria define it as at least 2 of the following symptoms in the last 3 months. Less than 3 bowel movements per week, a hard stool or lumpy stool, straining, a sensation that the anorectal region is blocked, a feeling that the person hasn't voided completely, and the need to manually evacuate or help evacuate stool from the intestinal tract. So, what could possibly cause all this trouble? What you eat and drink, or don't eat and drink, can play a humongous role in this problem. Dehydration is a major cause of constipation as the stool dries out. Why? Well, in order to help move the stool along your digestive tract, the poop itself needs to remain a bit moist and slippery. But if the person is dehydrated, the body tries to conserve water for more critical needs like the function of the cardiovascular and nervous system at the expense of the gut. This means water is reabsorbed from the bowel, the poop dries out, becomes hard, and the rest is history. Another dietary factor that may lead to constipation is an inadequate amount of fiber. Some of the fiber we eat attracts water to the stool, keeping it nice and moist, and thus helping us defecate nice and easy. But it's not that easy, actually. I only wish that what we eat or drink was the only thing that affects the propensity to develop constipation. There are plenty of other causes of this problem. One is diverticular disease, a general term that describes one of several disorders that cause the development of pouches in the wall of the colon called diverticula. Diverticular disease causes decreased transit times through the colon, which can predispose a person to constipation. By this, I mean the time it takes for the poop to go from point A to point B. The transit time, much like on highways, increases. Things back up, get stuck like in a traffic jam, and voila, we have constipation. Another potential cause of constipation is a problem with the nervous system. In the end of all ends, it is the nervous system that gives off the signal for proper gastric motility and the contraction of the muscles involved in defecation. This means if there is a problem with the brain, spinal cord, or peripheral nerves, then gastric motility may be reduced. This, again, increases transit times and causes constipation. In other cases, nervous disorders may weaken muscles like the abdominal muscles, which help evacuate the bowel as you strain. Drugs such as antidepressants, sedatives, opioids, anticholinergics, and antacids, and others may cause constipation too. Regardless of the cause, in severe cases the hardened stool may form into something called an impaction, an accumulation of hardened, compressed, immovable feces that obstructs the passage of stool. Ironically, diarrhea may be a sign of a fecal impaction. Care to guess why? Think about it. Your gut is like a pipe. In that pipe flows liquid stuff and larger, more solid stuff, the feces. If the pipe is blocked almost entirely so with something, what is more likely to get through the blockage? The malleable, smaller, slippery, watery things? Or the harder, larger stuff? Obviously, it's the watery stuff, the diarrhea. The impact this lesson should have had on you is hopefully not as hard to stomach as the feces and constipation. The gastrointestinal or GI tract, the digestive tract, may suffer from constipation, which is a symptom rather than a disease, which may be acute or chronic in nature and results in a decreased frequency in the passage of stools and or consists of stool that is hard and difficult to pass. When I say acute, then it's of sudden onset and or short duration. When I say chronic, I mean it is of long duration and or recurrent in nature. Very generally, constipation is seen as less than 3 bowel movements per week. Everything from diverticular disease, a general term that describes one of several disorders that cause the development of pouches in the wall of the colon called diverticula, to drugs, to nervous disorders, to dietary factors can lead to constipation, and ultimately to an impaction, an accumulation of hardened, compressed, immovable feces that obstructs the passage of stool. When you are young, you poop and pee your pants. That's pretty normal. No one really thinks anything bad about the fact that a baby has pooped its pants because it's expected. On the other extreme of age, when we get into our senior years, people over the age of 65 are also likely to have the same problem, which is called fecal incontinence. People younger than this can suffer from fecal incontinence, but it's not as common. In any case, this is a problem and is embarrassing since it's less expected and accepted by society. In this lesson, we are going to look more closely at this issue and define what fecal incontinence is and some of its major causes in adults. Fecal incontinence is the inability to control one's passage of stool. That means that a person who has fecal incontinence literally cannot control how much or even when they defecate through the anus. This problem is more common than you might think. Actually, about 1 in 12 Americans suffers from some sort of fecal incontinence, and hundreds of millions of dollars are spent each year on disposable underwear as a result. One of the main mechanisms behind fecal incontinence is the inappropriate function of the anal sphincter muscles, one of 2 muscles that control the evacuation of feces. This can most often occur due to a traumatic injury or a nervous system disease. Although the sphincter muscles are circular and close like strings around a bag, it's easier to think of the anal sphincter muscles as a gate at the end of a very long hose, your digestive tract. Once the gate opens, everything can rush out. If this gate doesn't work correctly, it can open at an inappropriate time, even if the person doesn't want to defecate at that moment voluntarily. Again, this gate can be injured and thus malfunction. A common cause of this among women is a childbirth-related injury to the anus. In this case, the door is partially broken and doesn't work well. Another cause of anal sphincter dysfunction is a nervous system disorder. In this instance, the doors look just right, meaning they aren't broken as if by an injury and look just fine. However, these doors receive electrochemical signals to open and close in order to control the passage of stool. In nervous system disorders, this electrochemical signal either doesn't get through at all, doesn't get through on time, or gets through in weird spurts. Think of it as damaged wires causing a poor signal to go through. Since the electrical signal to control the opening and closing of the doors is compromised, they don't work properly, leading to fecal incontinence. There are plenty of other potential causes of fecal incontinence, however. These include inflammatory disorders affecting the bowel, cancer, toxins that stimulate the bowel and cause the person to defecate, and very large volumes of stool relative to the storage capacity of the rectum. The latter one is not too hard to understand. If you've got diarrhea, a lot of watery stool can reach the end of your digestive tract very quickly. You may feel a sudden urge to go, but may not be able to make it to the bathroom on time, causing a single instance of fecal incontinence. What is fecal incontinence? At this point, you should know it's the inability to control one's passage of stool. You should also know that a major reason for its occurrence usually boils down to a problem with a direct or indirect problem with the anal sphincter muscles, one of 2 muscles that control the evacuation of feces. This means a direct injury to these muscles, causing anatomical dysfunction, or an improper signal to these muscles as a result of a nervous system disorder are to blame. SBD, silent but deadly. No, not a ninja. Farting. It's okay. Let's just get it out there and out of our system. I fart, you fart, your dog farts, we all fart. But why? How many of us have really stopped to think about why we are about to meticulously and cunningly poison the air around us? Ponder no longer. This lesson defines flatulence a bit more scientifically and explains the causes and process behind why we fart. Farting is more properly called flatulence, and there's nothing flat about the knife that cuts this cheese. That sharp smell is caused by the excessive formation of gas in the gastrointestinal tract that is then discharged from the rectum. While there are exceptions to this, the major process behind flatulence isn't too hard to understand. You need to eat. That food provides you with energy. Inside of your digestive system live little buggers called bacteria. The bacteria also need food to survive, so they mooch off some of the stuff you swallow in exchange for protecting you from deadly pathogens and helping you to digest your food. Some parts of that food, especially the parts not digested by your body, are to bacteria like coal is to a power plant. It provides the raw ingredients that produce energy. But what do we know about coal plants? They have chimneys that send malodorous waste gases out and into the air around them. Same thing with the bacteria. Using the process of fermentation, they produce waste gases like hydrogen, methane, and carbon dioxide as they convert the raw material into energy. These waste gases, including the malodorous ones like sulfur-containing compounds, are then expelled into the intestines and then into the air around you as you pass gas. Foods that bacteria love to use as raw ingredients include beans, prunes, apples, cabbage, and more. So, the next time you eat a burrito, you'll know why all of your friends have gone running for the hills. Besides the breakdown of normal food by bacteria, gas in the digestive tract can be caused by lactose intolerance and, in rare cases, by the excessive swallowing of air. There are also medical conditions that can cause flatulence. They include irritable bowel syndrome and small intestinal bacteria overgrowth. Flatulence usually isn't a problem, except to those around you. However, flatulence can be caused by serious issues or be part of a serious problem. This is why, if anyone experiences any of the following symptoms alongside a lot of flatulence, they should go to the hospital and get everything checked out. These include severe cramps, vomiting and nausea, diarrhea or constipation, fever, which may be a sign of infection, and blood in the stool, which is always a medical emergency. Treatment for flatulence really depends on the root cause. This is why a variety of treatments may be used, including dietary modification and antibiotics. Flatulence is a word that refers to the excessive formation of gas in the gastrointestinal tract that is then discharged from the rectum. The major cause of flatulence is undigested food reaching your gut bacteria. These guys then use the undigested food as raw material for energy production with waste gases, including smelly ones, being produced as a byproduct. These waste gases include hydrogen, methane, and carbon dioxide, and the smelly sulfur-containing compounds. Lots of food can cause increased flatulence, including beans, prunes, apples, and cabbage. If flatulence is accompanied by other symptoms such as fever, severe cramps, or diarrhea, you should see a doctor. You know that feeling? You know the one. When you're out at a restaurant, on a train, or just walking in the middle of a street and you realize that you have to go. Now. And not number one, but number two. Yep. It's because your stomach is churning, and your worst fear may come to pass if you lose control. It's diarrhea. What exactly is diarrhea anyways? Diarrhea is an increased frequency of bowel movements with a concomitant passage of liquefied stool. This is the standard definition of diarrhea anyways. It comes from the prefix of di, which means two or twice as much, and rhea, which means a profuse flow of something. There's actually a more proper medical definition of what we just call the runs. Another way to define diarrhea is a reversal of the net absorption of water and electrolytes in the intestinal tract to their secretion and excretion out of the body, meaning Instead of absorbing more water and electrolytes into our body, we are now ridding ourselves of more of them. And there's a third way to look at and define diarrhea, also from a medical perspective. Diarrhea can be seen as a stool volume of greater than 10 milliliters per kilogram per day in infants and young children, or a stool weight of more than 200 grams per day in teenagers and adults. Who knew there could be so many ways to describe so many of our memories on the toilet? In essence, diarrhea is really an increase in the water content of the stool. That's the important part of it. This, in turn, causes stool frequency to increase. One other thing, as with any topic in medicine, there are catches and exceptions to just about every rule and definition. For instance, the definition of a stool weight of more than 200 grams per day in teenagers and adults is applicable in most scenarios, but not all. This is because something called normal output diarrhea exists. This is where the stool output is less than 200 grams per day, but the person experiences hyperdefecation, abnormally increased frequency of defecation, as a result of things like anorectal disease, functional bowel disorders, and hormonal problems. However, from some perspectives, normal output diarrhea is actually a misnomer because true diarrhea entails an excess of water being secreted and expelled. This is what causes the liquefied stool. The three disorders I just mentioned may not have excess water being expelled and instead will only increase the frequency of defecation, hyperdefecation, or loss of control of defecation, incontinence, without a change in the consistency of the stool itself. Thus, the definitions for diarrhea all depend on how picky you want to be about the language you use. Anorectal disease, functional bowel disorders, and hormonal problems are some of the less frequent causes of diarrhea actually. More common causes for diarrhea include bacteria, such as salmonella, viruses, such as rotavirus, parasites or protozoa, like Giardia, drugs, cancer, intestinal disorders like irritable bowel, ulcerative colitis, and Crohn's disease, and food, be it due to overconsumption of certain foods, intolerance, or allergy. As with the many definitions and causes of diarrhea, there are many different types of diarrhea depending on how specific you want to be when classifying them. The two most important common types of diarrhea are known as osmotic and secretory diarrhea. In osmotic diarrhea, nutrients or other substances found in the intestines keep water in the intestinal lumen like a sponge. The intestinal lumen is the open empty space where food and feces move through in the intestinal tract. It's like the empty space within any tube for that matter. Normally, most of the water you drink is absorbed from the gut and into the body. In osmotic diarrhea, the water isn't absorbed into the body and diarrhea results. Osmotic diarrhea is commonly caused by nutritional issues. For instance, if you eat a ton of grapes, you'll get osmotic diarrhea because too much sugar in the intestinal tract draws water in. However, the good thing about osmotic diarrhea is that this type of diarrhea usually stops pretty quickly, especially when the offending nutrient is removed. If you ever have to run to the bathroom just once and never again, you can bet this was a case of osmotic diarrhea. You probably ate something that caused it. On the other hand, if you have to go to the bathroom over and over again, especially over many days, and even when you fasted, then this is more likely to be a case of secretory diarrhea. This is usually caused by a pathogenic, like bacterial, infection in the gut. This type of infection will cause the cells lining the intestines to actively secrete water into the gut. Loosen up. This lesson is over, so let's run over its important points again. We can define diarrhea in more than one way. An increased frequency of bowel movements with a concomitant passage of liquefied stool, a reversal of the net absorption of water and electrolytes in the intestinal tract to their secretion and excretion out of the body, a stool volume of greater than 10 mils per kg per day in infants and young children, or a stool weight of more than 200 grams per day in teenagers and adults. More common causes for diarrhea include infectious agents like bacteria, viruses, and parasites, drugs, cancer, intestinal disorders like irritable bowel, ulcerative colitis, and Crohn's disease, and food, be it due to overconsumption of certain foods, intolerance, or allergy. And the two main types of diarrhea are osmotic diarrhea, where a nutrient keeps water in the intestines, which means the water isn't absorbed into the body as it should be, or secretory diarrhea, where the cells lining the intestines actively secrete water out of the body's tissues and into the intestines.
When it comes to going to the bathroom, sometimes it's easy to go, and sometimes it's not. Since bowel elimination, which is the way your body rids itself of solid wastes, is a process involving the digestive tract, it's easy to see that things like the types of foods you eat and the amount of water you drink could influence your ability or inability to go to the bathroom. But there are many other factors that influence bowel elimination. In this lesson, we will look at the obvious and not so obvious factors. Let's start with one of the more obvious factors that influences your ability to go to the bathroom, your diet. Some foods contain fiber that promotes regularity and helps move food through the digestive tract. High-fiber foods like fruits, vegetables, beans, and whole grains add bulk to your digestive wastes, making it easier for you to move your bowels. In contrast, some low-fiber foods lead to constipation, which is a difficulty with bowel elimination. Dairy foods, such as cheese and milk, are common foods that can contribute to constipation. Along with diet, the amount you drink and the amount you move can also influence bowel elimination. The basic rule is that more fluid intake and physical activity is better when it comes to ease of bowel elimination. Physical activity and lots of water help speed movement of waste through the digestive tract. These factors are particularly important for people who aren't feeling well. If a person's illness prevents them from moving around or causes dehydration, the movement of food through the digestive tract slows down, which leads to harder stool and constipation. Sometimes it's not what's going on inside your body, but what's going on inside your head that influences bowel elimination. For example, psychological factors, such as a person suffering from depression, which is a mental condition characterized by prolonged periods of sadness, may experience a slowing of peristalsis, which is the muscular movements within the digestive tract that push food along. Habits can also develop due to thoughts or beliefs we have, and these habits can influence bowel elimination. For example, a person might not like to go to the bathroom while at work or school because they think it's not private enough or it's unclean. If this habit of avoiding the urge to go is prolonged, it can lead to constipation and make it hard to go when the time is right. Sometimes, seemingly unrelated factors influence bowel elimination as we move through the different stages in life. In fact, we see that age by itself can be a factor. For example, young children lack the physical maturity needed to exert control over the urge to move their bowels, whereas the elderly may lack the muscle tone needed to control elimination. In between infancy and our senior years, there are a number of conditions that can interfere with normal bowel movement. For women who are in the later stages of pregnancy, bowel activity can be reduced due to direct pressure of the fetus pushing on the intestines. Pain is something that can strike anyone at any age. If the act of having a bowel movement causes pain, either indirectly due to the pressure of bearing down, or directly due to things like hemorrhoids, the person might delay elimination or find elimination difficult. It's also possible to have problems develop due to a medical treatment. We see that different medications can have a laxative effect, which causes waste to move quickly through the digestive system, while other medications can lead to constipation. Surgery and anesthesia are two procedures related to healthcare treatments that can influence bowel movement. Surgery and the anesthetic agent used during surgery can cause peristalsis within the digestive system to slow or stop. Even if the patient makes it through the surgery without bowel elimination problems, they might still face an issue during their recovery. For example, some patients find it hard to have a bowel movement in a bedpan. This may have a psychological factor associated with it, but the inability to go can be due to the awkward position. Trying to have a bowel movement while lying down can be challenging. To remedy this problem, the nursing staff can raise the head of the bed to simulate the seated position. Let's review. Bowel elimination is the way your body rids itself of solid wastes. It can be influenced by lifestyle factors including diet, fluid intake, and physical activity. It can also be influenced by psychological factors and habits, as well as age, pregnancy, and the presence of pain. Sometimes bowel elimination is influenced by medical treatment or recovery, such as medications, surgery, anesthesia, and position.
You have a lot to learn about the GI tract and in particularly the bowel as you enter the field of nursing. Hundreds of years of research have proven that the bowel is very key to the overall health of an individual. Not sure why that is? Let's see if we can get some clarity. Take a moment to think about everything that you ate yesterday. Today, that combo meal from dinner looks nothing like what it did when you ate it. It has gone through the process of digestion and is likely somewhere in your bowel or gut by now. It is in semi-solid form and contains lots of acid and bacteria that are necessary to finish breaking it down. Now, would you want any of that to enter the rest of your body? Of course not. That is why our GI tract is a closed tract to the rest of the body. Very bad things happen in the body when the contents of the GI tract get into the bloodstream or other parts of the body. Bowel integrity, or the barrier of the bowel wall, is crucial to making sure the contents of the bowel stay in the bowel. Are you getting the picture now about why the bowel is so important to our overall health? There are different methods that we can use to help determine what is going on with the bowel. Now that we know how important the bowel is, let's look at the methods to assess bowel integrity. The first method that we use is getting the information about a patient's current and past health, which we call the patient history. You will need to find out every condition or disease that the patient is currently or previously diagnosed with having. This is important because certain diseases and conditions may make a patient more prone to develop problems in the wall of the GI tract. We also need to know about past surgeries, since some of those can also lead to GI tract problems. This is especially important if the surgery was recent and or performed on the GI tract itself. Consumption of certain liquids, such as alcohol, can cause drastic changes in bowel habits and bowel integrity. The medications that the patient is currently or recently taken should also be documented and taken into consideration. Many medications may cause changes in the bowel elimination and possibly even the bowel wall itself. So we have the patient history as it may relate to the bowel issues, and now we need to use some techniques to test the integrity of the bowel. When you hear the word integrity, you may think about being honest, but it also means being whole without openings or divisions. Bowel integrity has to do with the wholeness of the bowel. Remember that we want the bowel to be closed off to the rest of the body without any holes or other openings where the contents can escape. We have different physical examinations that we can do to help determine bowel integrity. The first technique is a barium enema. This is the insertion of barium through the anus and rectum into the bowel colon. The barium will coat the walls of the colon to allow for clearer x-rays to be taken. The film from the x-rays will be studied to look for holes or thinner areas in the bowel wall. If there are areas that are not coated with barium, then this could signify a possible opening in the bowel. Areas where the white coating is not as intense could indicate that the wall is thin in that area and may open up soon. The next physical exam is a colonoscopy. This is a visual examination of the colon using a colonoscope. The physician is able to directly view the walls of the colon to look for openings or weakened areas in the bowel wall. The bowel is so very important. Let's recap what we covered. Bowel integrity is a barrier of the bowel wall. The different techniques to help determine bowel integrity include taking a patient history, getting the information about a patient's current and past health, diseases, conditions, surgeries, medications, and liquids consumed should be documented. Doing a barium enema. Insertion of barium through the anus and rectum into the bowel or colon. This makes holes or weakened areas show up easier on X-ray. Doing a colonoscopy. Visual examination of the colon using a colonoscope. This gives a direct view of the walls of the bowel or colon.
You may not have spent much time thinking about it before, but our bowels have a really important job in the body. We eat on a regular basis to get the nutrients and energy that we need in the body. The food and nutrients pass through our GI tract to be digested and extracted. We don't want to keep the digested food that is depleted of nutrients, now called feces, in the lower bowel forever. That would be very uncomfortable. The release of feces to outside the body, known as bowel elimination, should take place at the appropriate time. Not being able to eliminate feces can wreak havoc in the body, as well leading to different conditions and diseases. In this lesson, we'll take a look at the different ways to assess bowel function in patients so that you can easily recognize when things aren't running smoothly. One of the best starting points for assessing bowel function is to get information about a patient's current and past health, which is known as the patient history. This is key to understanding what may be going on with patients and impacting their bowels. Eating habits should be questioned when recording patient history. There are times when patients come in complaining of not being able to excrete bowels, but then we find out that they haven't been eating anything either. If nothing goes in, then we don't expect anything to come out. What the patient eats is as important as how often they are eating. Drinking is important because we need to know the amount and types of liquids being consumed. People need a certain amount of water in order to be able to form and release feces. The patient's daily life and activities are one of the last key things to be discussed and considered when looking at possible GI tract problems. An active patient should have regular bowel movements, whereas a sedentary person may have less. A patient that is under a lot of stress could experience changes in bowel habits as well. Stress may increase or decrease frequency of elimination and will almost certainly change the consistency of feces being eliminated. Recent surgeries and medications can also give clues to changes in bowel function. Some surgeries and medications alter the frequency of bowel elimination and consistency of feces being released. It's time now to look at how we determine bowel function. Everyone has a normal amount and frequency for bowel elimination. The majority of people will have anywhere from 1 to 3 bowel movements a day for at least 3 to 5 days out of the week. It is key to know the patient's norm for bowel elimination in order to determine changes in function. Observation involves watching a patient's bowel habits. You are to observe almost everything about a patient's bowel movements. When, how much, how often, and type should be observed. The second part of this assessment is charting, which is documenting the observations. This is important to better keep track of the observations. Most people cannot keep up with their own bathroom habits, let alone the habits of someone else. As a nurse, you will be responsible for knowing the habits of many patients at the same time. Observation and charting will help you to stay on top of the bowel functions of all of your patients. The first way that we can detect changes is by auscultation, which is simply listening to the bowel. It isn't going to talk to us per se, it will make noises as it works. There are noises that are considered to be normal bowel sounds and ones that are considered to be not so normal. I'm sure you can relate to having an episode where your bowels were making very loud noises that sound like heavy water moving around. You instantly knew that you need to be close to a bathroom because you were about to have diarrhea. That is what we are listening for with our patients as well. The next test is to view the abdominal area. There is a certain expected curvature of the abdomen when the bowels are normal and functioning properly. If there are areas protruding or enlarged, this could indicate a possible problem in bowel structure and therefore function. It's time to touch and feel, also known as palpation, on the bowel now. You can press and feel around on the bowel area, checking for any abnormal areas. This will help to detect masses and tumors that could lead to diseases and/or cancer. As this is done, you should ask the patient about any discomfort they feel as you are pressing on their abdominal region. This can help you determine areas that are tender in the bowel and where possible problems may be brewing. Another assessment technique is percussion, which is a tapping on the bowel region. The tapping on the bowel makes different sounds depending on if it is full or empty and if the wall is enlarged or normal. The sound will also differ if the contents in the bowel are solid, semi-solid, or liquid. A more dull sound could indicate a problem such as an obstruction in the bowel. The last of the physical assessments is to do a rectal examination. You are looking for any abnormalities in the structure of the rectum and anus, such as masses. The sphincter muscle should also be viewed to be sure it is still toned and functioning properly. The rectal examination is used to check the feces that is contained in the rectum for consistency, color, and amount. It would only make sense that we should also check the finished product once it is released. This means doing a fecal examination or inspection of the feces. Yep, you're going to inspect your patient's poop. Lucky you! You are checking the color, consistency, amount, and even smell. All of these are indicators of how well the bowel is functioning. We learned quite a bit of information about how we assess bowel function. Here's a quick recap of the highlights. The release of feces to outside the body is known as bowel elimination. We assess patient's bowel function by doing the following. Patient history. Get information about a patient's current and past health. Observation involves watching a patient's bowel habits, and charting is documenting the observations. Auscultation. Listening to the bowel sounds. View the abdominal area for normal structure. Palpation, touch and feel. Percussion, tapping. Rectal examination, looking for any abnormalities in the structure of the rectum and anus. Fecal examination, inspection of the feces.
Before entering the nursing field, you probably didn't spend much time thinking or caring about the frequency and consistency of another person's bowel movements. Well, this is now one of your concerns. As a nurse, one of your responsibilities is to make sure that your patients have normal bowel movements each day. If a patient doesn't have normal bowel movements, it is also your responsibility to administer agents to help make the bowel movements regular again. In this lesson, you'll learn how to promote bowel elimination, also known as defecation or the discharge of waste from the rectum, to help a patient that is suffering from constipation or not having or having difficult bowel movements. There are different types of bowel elimination agents. The first type is one that you yourself may have used at some point in time. Oral laxatives are oral agents that help the bowels to move and excrete feces. We'll look at these from the gentlest to the harshest. Oral bulk formers are laxatives that absorb water into the bowel to form soft and bulky stools. These are available over the counter and are administered in the hospital setting as well. Examples of oral bulk formers are high fiber supplements that get dissolved in water like Metamucil and Benefiber. Oral osmotics are agents that use osmosis to move water from the tissues to inside the bowel to form soft stools. Some common oral osmotics include magnesium citrate, Miralax, and milk of magnesia. The latter of these are used frequently in the hospital and long-term facility settings and available for purchase over the counter. The last of the laxatives are the oral stimulants. These are the agents that increase peristalsis or contractions of the intestinal muscles to move feces out of the bowel. Oral stimulants are pretty harsh on the body and should only be used if other agents haven't helped to relieve constipation in the patient. Examples of oral stimulants include bisacodyl, which is sold under the names Dulcolax and Correctol. Another possibility for helping your patients have a bowel movement is to give them stool softeners. The name tells you exactly what these agents are and what they do. They are agents that soften stools. Softening the stool helps to allow them to be passed through and out of the bowel. The most commonly used stool softener is Docusate. This is available by prescription and sold under the names Colace and Surfac. Rectal suppositories are yet another option to help relieve constipation in patients. These are solid or oily agents that are inserted into the rectum that cause the release of feces. Some suppositories are Bisacodyl, Docusate, and osmotics like we just discussed. They work in the same manner as they do when ingested. The only difference is simply which end it goes into. Other suppositories such as potassium bitartrate, sodium bicarbonate, are carbon dioxide releasing agents that cause the buildup of carbon dioxide gas. The gas builds up behind the feces and forces the feces out of the bowel as the gas makes its way out of the bowel. There are many brand names under which these rectal suppositories are sold. Mineral oil, an agent that acts as a water sealant, can also be inserted into the rectum to relieve constipation. The oil makes the walls of the bowel waterproof so the water will remain in the bowel, allowing the feces to stay loose. The oil also provides a slick surface for the feces to slide out. This particular agent is generic and available over the counter under numerous brand names. One of the last agents that you may have to use as a nurse in order to help relieve constipation in your patients is an enema. This is a liquid agent inserted into the rectum to force the release of feces. Enemas may be used to relieve constipation, but they are more frequently used to clear out the bowel before a surgical or medical procedure. Enemas may contain different substances in order to help release feces from the bowel. A common type of enema is a soap suds enema, which is also called a cleansing enema. This can be purchased, but is most often made up at home or in a medical facility using soap and water. The soapy water helps to soften the stools and allows them to slide out easier. Patients are normally in a hurry to get relief from constipation, but it is your job as a nurse to take the time to educate patients on constipation relieving agents. Here are some key points that you need to make sure your patients know. First, they should know what is being administered to them. Give them a brief description of the agent being used and let them know what to expect from the agent. This can include how quickly they will see results and frequency of bowel movements. You also want them to know how to determine if their bowels are moving too much. Next, they should know the possible side effects of the bowel releasing agent. The possible side effects are fairly similar for each of the agents that we discussed. The side effects include diarrhea, stomach cramping, bloating, nausea, and vomiting. Some extreme side effects include water electrolyte imbalance, dehydration, severe stomach pain, rectal bleeding, and continuing or worsening constipation. Lastly, they need to know when it is time to seek medical attention. Emphasize the severe side effects and let them know that if they persist, then medical attention is necessary. You are all set to start offering relief to your patients. Another one of your roles as a nurse should be a lot clearer now. We discussed the different agents that are used to help eliminate feces from the bowel. We first learned that constipation is not having or having difficult bowel movements. The first set of agents discussed were the oral laxatives, which are oral agents that help the bowels to move and excrete feces. The classes of oral laxatives are oral bulk formers, laxatives that absorb water into the bowel to form soft and bulky stools; oral osmotics, agents that use osmosis to move water from the tissues to inside the bowel to form soft stools; oral stimulants, agents that increase peristalsis or contractions of the intestinal muscles to move feces out of the bowel. We then discussed that stool softeners are agents that soften stools to aid with elimination. Next, we discussed the use of rectal suppositories, which are solid or oily agents that are inserted into the rectum that cause the release of feces. Some are the same agents as the oral laxatives. The other two types discussed are potassium bitartrate, sodium bicarbonate, which are carbon dioxide releasing agents that cause the buildup of carbon dioxide gas, and mineral oil, which is an agent that acts as a water sealant. The last agent discussed is an enema, or a liquid agent inserted into the rectum to force the release of feces. As a nurse, you are responsible for covering the following patient education points in regards to bowel elimination agents: what is being administered, possible side effects, when further medical attention is necessary. You have recently started working at a skilled nursing facility. A new patient, Joyce, has just been admitted. You review her chart and see that Joyce is 72 years old and recovering from a CVA, commonly called a stroke, that occurred 2 months ago. The stroke has drastically reduced movement on the left side of her body. The doctor has prescribed several medications, including oxycodone, to improve Joyce's condition. Her doctor has also recommended that she begin physical therapy, but she was reluctant to do it while she was at home. Now it is time for you to use the nursing care process to determine the best care plan for Joyce. The first step in the nursing care process is to do an assessment. You interview Joyce to get more information from her. She tells you that she hasn't walked in about 3 months and is taking several medications for her condition, including oxycodone. Her daughter recently started her on some over-the-counter laxatives since she was complaining of constipation. At this point, you should get more information in regards to Joyce's constipation complaint. Pause the video now and think about what questions you should ask Joyce. Hopefully you came up with these questions. How often do you have a bowel movement now? How often did you have bowel movements before the constipation started? How long have you felt constipated? What color are your feces? Are your feces solid, runny, or in between? Joyce lets you know that she used to have bowel movements twice a day, and now she has them about once every 3 days for the last month and a half. The feces are solid, small balls that are dark brown in color. As part of the assessment, you should attempt to pinpoint what could be causing Joyce's constipation. Take a minute now to consider possible causes based on the information Joyce has provided to you. The factors that you should have come up with for causing the constipation are her recent stroke, immobility, and the opioid medications that she is taking. Putting this together brings you to the next step in the process, which is the nursing diagnosis. In order to come up with a diagnosis, you should obtain a couple of stool samples and do observation on Joyce for the first few days. You observe that Joyce has a bowel movement that looks just like she described on the day she arrives, and the next bowel movement isn't until day 3 and has the same characteristics. Testing the stool sample for parasites and occult blood, which is blood in the feces that isn't visibly apparent, doesn't produce any abnormal results. During this observation time, Joyce doesn't feel the need to take oxycodone for pain, but she also doesn't get up from the bed. Pause the video now to determine your diagnosis in regards to Joyce's constipation. The most likely nursing diagnosis for Joyce would be that she has constipation due to immobility induced by a recent CVA. Now that we believe we know what has caused Joyce to be in this condition, we need to come up with a plan to help her recover. Joyce's constipation is related to her lack of movement. Pause the video to think about some nursing interventions that can help Joyce to have more bowel movements. Consider the desired outcome for Joyce in regards to her bowel movements. Joyce is having bowel movements once every 3 days. A good outcome for Joyce is to get to at least one soft bowel movement each day that has the normal brown color and isn't forced. The nursing interventions could include getting Joyce out of the bed. Another advantageous intervention for Joyce is to start physical therapy to increase movement even more. We have our plan all set for Joyce. The next thing that has to happen is implementation of Joyce's care plan. Pause the video and think about ways to implement the nursing interventions in order to achieve the outcome we set for Joyce. Here's what implementation of Joyce's plan should look like. Joyce should be assisted out of bed at least twice a day to get her moving. The physical therapy team is going to work with Joyce once every other day so that she is exercising and using her muscles regularly. Joyce's bowel elimination problem isn't due to her diet, but she could still benefit from having more fruits and vegetables, which help to facilitate bowel movements and improve stool softness. A mild oral stool softener is added to Joyce's medication in the morning and evening. We are to our last step now. This is where we evaluate how our plan is going for Joyce. Joyce's plan has been implemented for 10 days, and all nurses that have worked with Joyce have carefully observed her bowel movements. The nurses have recorded that Joyce began having a bowel movement every other day starting from day 2 after implementation. The stool is still solid but comes out as short pieces of feces as opposed to small balls. The feces are still brown in color. You ask Joyce how she is feeling about her bowel movements, and she tells you that it is a little bit better. You also inquire about how physical therapy is going. Joyce says she is still scared of getting up because she doesn't want to fall, but she is getting more comfortable with doing it each time she goes. How would you assess this patient outcome based on the goal that was set for Joyce? Are any changes to the plan necessary? If so, which one? Pause the video and answer these questions. An accurate evaluation of the plan is that it is beginning to work to change Joyce's condition. There has been some improvement in just a short period of time, and the patient is becoming more comfortable with the physical therapy and other interventions that are necessary to improve her bowel movements. It is best to set another date about 10 days out to evaluate the status of Joyce's bowel movements again and see how she is feeling and doing with this plan. In this lesson, we did a case study on bowel movement elimination using our 72-year-old patient Joyce that is recovering from a CVA. Here's the process we followed. Assessment. Joyce has bowel movements once every 3 days that are small solid balls. The factors that could have caused the constipation are her recent stroke, immobility, and the opioid medication that she is taking. Diagnosis. The most likely nursing diagnosis for Joyce would be that she has constipation due to immobility induced by a recent CVA. Planning. Patient outcome for Joyce is to get to at least one soft bowel movement each day that has normal brown color and isn't forced. The nursing interventions include getting Joyce out of the bed and having her start physical therapy. Implementation. Joyce is assisted out of the bed at least twice a day. The physical therapy team is working with Joyce once every other day. More fruits and vegetables are added to her diet, and a mild oral stool softener is added to Joyce's medications in the morning and evening. Evaluation. There has been some improvement in just a short period of time, and the patient is becoming more comfortable with the physical therapy and other interventions that are necessary to improve her bowel movements. She will be evaluated again in another 10 days.